Everybody is able to see my screen?
Yes, sir.
Yes, sir.
आवाज कम करो थोड़ा.
Okay. So let's make this an interactive session. People, can you tell what is this? ये वीडियो किसका है? What is this video? Anyone? So this is basically a microscopic vision of, सब अपने आप को वो अपना जो डिवाइसेस से 2-3 से किया ना, तो आप वॉल्यूम कम कर दें प्लीज. So this is basically nothing but a microscopic section of alveoli with that are being ventilated at conventional ventilator. Okay, why it is like that we will discuss. And what is this? Anybody? Anyone? What is this video?
Bronchial.
Sorry. Yes, yes, good, good. So this is, or if you don't want to speak, you can chat in the, you can write in the chat box also. Okay. So, and you can see that I have put this video of HFOB alveoli, how they have been ventilated. Then why I have put a dog over here, panting dog? Is there any relation between these two, or just like that I have put a dog? Anyone? So there is a correlation. That's why this dog panting and this thing is there. Okay. So why? Because the idea of HFO, high frequency oscillation of oscillator, came into mind when the researchers they saw the dog panting. Why the dog pants? Dog panting क्यों करता है? Anyone? Okay. I am creating a poll. You please answer. Why dog pants? So I'm sharing this. Please answer. Answer the polls. Why dog pants? To lose heat is one choice. To breathe is one choice. If you log in through any of the devices, laptop or phone, you can do this. Answer this poll. So till now I have received 9 responses. So 4 of that, इसमें coffee डालना है. 4 of you, 5, 11 out of 11, 5 have written to lose heat and 6 are written to lose breathe. So I will end this poll here. It is basically to lose heat. Dog pants to lose the heat. Okay, that's why they do it. Okay, so that is why they're doing this. They're losing the heat. So that's why you must have seen the dogs sitting in cold water drains and doing this. So this is how they will lose the heat. But this main mechanism of losing this heat is through the lungs. They lose the heat through the lungs. It is not for breathing. Okay, so that's how the people thought of high frequency oscillator ventilation. Okay, fine. So anybody can see this animation? Everybody can see this animation? Please say yes or no.
Yes, sir.
Yeah.
Yes, sir.
So what it is showing? What it is showing? This ventilation is showing what? ये क्या है आपको नॉर्मल मैकेनिज्म नहीं है ब्रीदिंग का? दिस इज हाउ वी ब्रीथ. सो व्हेन वी ब्रीथ, व्हाट काइंड ऑफ मैकेनिज्म इट इज? पॉजिटिव प्रेशर वेंटिलेशन और नेगेटिव प्रेशर वेंटिलेशन? एनीवन? रेजिडेंट्स? what we breathe as humans, do we do?
Negative.
Yes. So it is negative pressure.
Negative
ventilation.
pressure, sir. Negative pressure.
So this is what is happening. So diaphragm, what it does, see, when the diaphragm contracts, it increases the intrathoracic volume and hence create a negative pressure in the thorax, which is the airtight cavity, and hence the air rushes through the trachea into the thorax cavity, that is in the lungs. Okay, and when it moves out, the positive pressure is created intrathoracic, and hence the air moves from the lungs out. So what we do as a natural mechanism is a negative pressure ventilation. And when we ventilate someone, what kind of ventilation is that?
Positive pressure.
Yeah, so that is your positive pressure ventilation. Great, good. So first thing we need to know, what we do naturally is negative pressure ventilation, and what we does artificially is positive pressure ventilation. So that's why we write it PPV, positive pressure ventilation. But that is the artificial ventilation what we does. Okay. Okay, this is basically, who is this? Anyone? I've just written the year. Who is this? Okay. So why I'm trying to bring this, because this is very important from the historical point of view, from the historical point of view of neonatology. Anybody who's sitting there, if you want to just write in the chat box, you can write. I will see. Yes. So Pratin has written, it is John F. Kennedy. And Nirmal sir has also written the right thing. It is John F. Kennedy. Why John F. Kennedy is important for the history of neonatology and neonatal ventilation?
Because his son,
Yes, please.
for his son, ventilator was not available.
Yes. So actually, John F. Kennedy had twins, and they were 33 to 34 weeks, 32 to 34, had respiratory distress, and there was not a single ventilation for the neonatal ventilator was there in the US. Only 2 neonatal ventilators were available in Canada, and they were patients, they were on the patient. So when America requested Canada for the ventilator, they told our 2 ventilators are already on the patient, and those 2 twins of John F. Kennedy died at that time because of RTS in 1963. So that changed, because then at that time they put a lot of money and efforts in neonatology, and that was a real turnaround for the neonatology and neonatal ventilation. So that's why this incident was very important in the history of neonatology. They died on second day. Okay, as no surfactant and no ventilator was available at that time in USA. So what is ventilation? When we start with the neonatal ventilation, so what is ventilation? By simple definition, it is just a movement of gases in and out of lung by some external source connected to the infant. Clear? In simple definition, the ventilation is the movement of gas in and out of lung by some external source which is connected to the infant. So when we talk about that, when we ventilate, positive ventilation, we do positive pressure ventilation. So what are our aims? Our aim first is to achieve adequate gas exchange without causing an injury to the lung. So these 2 points are, see, gas exchange we have been doing, okay? That is okay. Gas exchange is okay. But the main crux nowadays when we talk about is the injury of the lungs. We have to do the ventilation by preventing the injury to the lungs. That is very important. So that's why whatever strategy we adopt for ventilation should be pathophysiological, that it should match with the normal physiology of the ventilation. What is the normal physiology of ventilation? We discussed that. What is the normal physiology for ventilation? Anyone? We discussed that. हमारा नॉर्मल वेंटिलेशन का टाइप कौन सा है? नेगेटिव प्रेशर के पॉजिटिव प्रेशर?
नेगेटिव प्रेशर।
यस. सो अगर हमारा नेगेटिव प्रेशर है तो इट मींस लंग में मिनिमम इंजरी किसके साथ होती है? पॉजिटिव प्रेशर वेंटिलेशन के साथ कि नेगेटिव प्रेशर वेंटिलेशन के साथ?
नेगेटिव के साथ।
Minimum injury will be with the negative, because that is our normal physiological process of ventilation. So there is no injury in the negative pressure ventilation. But what we are doing is positive pressure ventilation. It means it will cause some injury. So that's why we have to be careful when we do artificial ventilation. So that's why our strategies should be as nearer to pathophysiology, natural pathophysiology as possible. But it is not 100% achievable. And therefore, now all the current evidence says that strategy should be kinder and gentler. So we should do a gentler ventilation. And when we do the ventilation, the patient should be comfortable on it. Okay, it should not affect the comfort of the baby. That is very important. So these are our aims: 1, 2, 3, and 4. They are very important. As we have discussed, negative ventilation is the physiological ventilation, and whatever ventilation we do artificially is a positive pressure ventilation. Clear?
Yes, sir.
Okay. So this is what we have discussed. It is the movement of the gas in and out of the lungs to a source connected to the infant. These are our aims. We have already discussed those. Okay. Now see what is happening. This is basically, I am trying to explain the physiology of ventilation. This is what I just explained in that animation. The diaphragm moves down. These intercostal muscles, when they contract, so they move the ribs up. Can anybody tell what is this mechanism called when this rib move upward with the intercostal muscles when they contract? What is the name of this mechanism? Anyone? Or you can write in the chat box.
Bucket handle.
Yes, my buckle handle. Sir is number one in answering. Sir is answering everything. Wow, great. So must see the chat. Dr. Nirmal sir is answering all the questions. So it is buckle handle mechanism. So that's how it creates the more space. So negative pressure within the chest, and hence the air rushes in through the nostrils, through the trachea into the lungs. Lungs get filled, and then this diaphragm moves up. And these things, they come down and hence create a positive pressure in the intrathoracic, and hence the air rushes out from the lungs to the atmosphere. As we have discussed, negative pressure ventilation is safe and natural, but it is can you identify what is this? Ye picture kiska hai?
Yes, sir. Iron dome ventilator.
Yes, so this is iron lung. So when the ventilation started, people started the ventilation as a negative pressure ventilation, and they developed this iron lung. So they used to put the whole body, just the face out, in this jacket of the iron, and then they used to increase and decrease the pressure inside here. So the chest used to move up and down, and air used to flow through the normal our respiratory tract. So that is your iron ventilation. Oh, okay. Sorry. So through Dr. Nirmal sir, this thing, it has been written. Residents are answering that. Oh, great. Nice. Sorry. So all the residents are answering. Great. That is much better than. Okay. So this is what used to happen. But now you think, if you have to ventilate, how you will take care of that baby? If that whole baby is inside the iron lung, if you want to even take care of change the diaper of the baby, you have to stop the ventilation for that. And to transport this kind of patient with such a big machine, it is very cumbersome. Okay. And then the patient can be awake. See, the patient is awake, watching TV. So it is really cumbersome to do this. So that's why from negative pressure ventilation, people shifted to positive pressure ventilation. So that is very important. So that's why now all the ventilation, what we do in our day-to-day practice is positive pressure ventilation. So what is positive? Is a simple mechanism. If I want to tell you, this is a limb from where the air moves from the ventilator towards the patient. So this is the limb. So here the air comes in, is being pushed by the ventilator. It moves through this pipe, and there is an outlet like ET tube is been attached to this patient. So the patient gets the air from here, and when exhales out, and that air, it goes out through this outlet. Okay. So during the inspiration, what happens? If you close this, close this outlet, the air which comes from the ventilator will move in towards the patient, and hence it will inflate that alveoli. And when in expiration, what happens? The air will go up from here and it moves out. Okay, when it opens up. So this is the basic mechanism what is happening in our positive pressure ventilation. Now the question for you, should this outlet flap, it should be completely open or partially open? Let's do a poll. What will happen? Huh? What will happen? When the outlet lid completely opens, then what will happen? Lung will collapse or lung will ventilate very well? Total 5 responses. Total 8 responses. 11 responses. 12. So let 12 people have responded till now. 13 people have responded. 12 have written lung collapse and 1 has written ventilate well. So it will be lung will collapse. Why? Why it will collapse? Anyone? Any one of you can put in the chat.
पॉजिटिव एंड एक्सपायरेटरी प्रेशर मेंटेन नहीं होगा.
Yes. Okay. Loss of PEEP, and there will be a collapse of lungs. Very nice. Because if it completely opens in expiration, the whole air will go out and the lung will collapse. Everything will go out. So it means it should not open completely. It should be a partial opening only. Okay. That is very important. So this is what it is. So this is what is happening in conventional ventilator. In inspiration, we have PIP. What is the full form of PIP?
Peak inspiratory pressure.
Peak inspiratory pressure. And what is the full form of PEEP?
Positive and expiratory pressure.
Very good. Positive and expiratory pressure. Fine. So what happens? See, in PIP, this is partially, not completely closed. Otherwise, completely closed, the whole air will go into the baby's lung and cause pneumothorax. How much pressure we need in PIP that needs to go to the baby. On the basis of that, this thing is closed and open, that much area. So that much PIP the baby will get. Okay, in expiration, you see it is not completely open. It is partially still, it is partially closed. So the more air will be let out, but some air will be there because the pressure will be generated because of this flow of the air. And hence it is the basal flow which will cause PEEP. PEEP is something which is a minimum pressure that needs to be there in the circuits, whether the baby is in inspiratory or expiratory phase, because we need some pressure in the circuit to keep the lung or alveoli open. Otherwise, if there is a zero pressure in expiration, the lung will collapse. The intra-alveolar pressure will be gone out and hence the lung will collapse. So that's why you need to have some pressure in the circuit, in the airways of the baby in all the phases of respiration. That is in inspiration and expiration. And similarly, it holds true from hemodynamics point of view. Like if you think in systole, the heart pumps, okay, there is a systolic pressure. In diastole, when the heart dilates, in diastole, if there is no flow in the vessels, okay, so there will be no blood flow to the brain. So you will go into syncope. So in every diastole, you will go into syncope if there is no flow in the diastole. So similarly, the body needs a blood flow, even systole and diastole both. Similarly, your air needs the pressure, your lungs need pressure and airflow in systole and in inspiration and expiration both, in order to keep the alveoli open. Natural, that what we call that residual pressure or residual air, what is it is known as when we talk of the physiology of the respiration? Anybody can tell?
Residual volume.
Yeah, so it is end expiratory residual volume. Okay, there is the end expiratory residual volume. So that should be there to keep the alveoli open. Okay, that's how this mechanism happens. So as I showed in the previous slide that it completely opened, it is not like that. Actually, this is what is happening in the real world. Okay, clear? Till now, everything is clear?
Yes, sir.
Okay.
Yes,
Yes,
sir.
sir.
So now I have written one thing. We will discuss about that, but this is what I've written. If you can understand, time cycled pressure limited ventilation. Anybody can explain if somebody understands this? What is this? If you don't understand, it's fine, because we will be discussing this. If somebody understands, can explain. Time cycled pressure limited. Okay.
Sir,
Hmm.
time cycle means respiratory rate is controlled by time,
Mhm.
and maximum limit is pressure limited by pressure. Sir.
Good. So it means how much breath needs to be given is been time cycled, is been time oriented, and how much pressure needs to go up and down is been controlled by the pressure limitation. Okay. So this is what you must have read many places, TCPLV, time cycle pressure limited ventilation. Okay, what it is, we will discuss regarding that. And but actually it is positive pressure ventilation only, whichever mode. So now see what we will discuss that in detail, because that is something which is very important to understand. So this is spontaneous inspiration is what? It's a volume change in the intrathoracic. With the change in the volume of the intrathoracic capacity, there will be a difference. It will create a difference in the pressure in intrathoracic and extrathoracic, that is outside the lungs. And hence it will cause the flow of the gas, because gas flows from where to where gas flows? Gas
Higher
flows
pressure
from
to negative pressure, lower
Yes.
pressure.
high pressure to low pressure. So therefore, in inspiration, what happens in intrathoracic? In negative pressure ventilation, what happens? Negative pressure is created in intrathoracic. In the inspiration, okay, in inspiration, negative pressure is created in intrathoracic, and hence air moves from out to in. And what happens in inspiration, expiration? When these things go in, the pressure in the intrathoracic increases, and hence the air moves out from intrathoracic to extrathoracic. Clear? Clear?
Yes, sir.
Yes.
Okay. So now this is what is happening in mechanical ventilation. There is, see, in volume ventilation we do that, but everything is being happening in the ventilator. So that pressure difference, how it is created? The ventilator will create a pressure with the higher pressure in the ventilator as compared to what is there in the patient's chest. Therefore, the negative pressure is not created within the patient chest. The pressure, high pressures are created at the ventilator. This is a ventilator. It creates higher pressure of air, and this is your patient. This is your patient. So there in natural ventilation, we were generating negative pressure here. So the normal pressure became high pressure for inside the thoracic. Therefore, the air movement was there. But now we do not create a negative pressure in the intrathoracic in patient. It is a normal pressure, whatever it is. So we have to create a pressure here in the machine higher than this pressure. So the mechanical ventilator will generate that pressure, and hence the air will move from a machine to the lungs in the thorax. Okay. And this is in inspiration. In expiration, what happens? The pressure here goes down. So already there is a air inside, lungs are inflated. So the pressure is high. As the pressure here goes down, the air will move from lungs outside. And that's how the positive pressure ventilation works. And this is what I'm trying to explain here. So what has happened? We are creating the higher pressure, which is causing the gas flow. And that gas flow, because of that pressure difference, is causing the volume change. So this is pressure ventilation. And in natural ventilation, volume change is causing the pressure difference, and that is causing the gas flow. Did you understand what I'm trying to tell?
Yes, sir.
Yes, sir.
So that means your ventilation, your normal ventilation is basically a volume ventilation, isn't it? Natural ventilation is a volume ventilation. So that's why we will discuss that later, that's why now people are moving more towards the volume ventilation instead of pressure ventilation. This is your natural ventilation, and this is your mechanical ventilation to start. Nowadays, we do it differently by volume mode, but this is how the machine does it. Okay, so this is these two slides are very important to understand between the difference between mechanical ventilation, what we do, artificial ventilation, and then how the natural ventilation is being done. Okay, so these are the basic mechanism of positive pressure ventilation: pressure difference, gas flow, time and volume change. Because how much the volume will change will depend upon the time for how much the gas inflow comes in. Okay, for how much time the gas inflow comes in, that much volume will change. So that's why it is very important. Till that point, everybody is clear?
Yes,
Yes,
sir.
sir.
Yes, sir.
Great. So now I've just, till now what I have done is I have explained you a bit of history, a pathophysiology, what is happening in the negative pressure ventilation, that is our natural ventilation, and what is happening in our positive pressure ventilation, and what are the different mechanisms by which the gas flow is happening. Now, I'm not going in detail of respiratory pathophysiology. I'm just taking very basic in broad things. Okay. So now you see that how when we talk about these curves, ventilatory graphs. So when we talk about these curves, how these curves, they are seen in spontaneous ventilation. What is spontaneous ventilation? Which type of ventilation is spontaneous ventilation?
Negative pressure.
Negative pressure.
Negative pressure, yes. Great. So our spontaneous ventilation is negative pressure ventilation. Great. Now you see, that's why in inspiration there is a negative flow.
Negative flow.
In expiration there is a
Positive.
positive. This is as per the pleural
Yes.
pressure. And this is happening in the flow. Negative pressure is created intrathoracically, a positive flow is being created. Okay, a positive pressure is being created intrathoracically, and negative flow is happening. This is with respect to the chest. Do you understand this? No.
Yes,
Yes,
sir.
Sir, flow का नहीं समझ आया.
See, this is your chest. So how I am doing this? I have suppose if I have some instrument, and the tip of instrument is lying within the chest here. Okay, so the air flow which is moving inside the chest is what is moving towards this instrument. So for this is a positive flow. This is positive
Yes,
flow.
sir.
And when this air is moving away from this, it is a negative flow.
Negative flow.
This is what is happening. So
Okay.
when there is an intrathoracic negative pressure was being created, the flow is inside the chest, that is towards this. So that's why it is positive flow. And when the positive pressure is being created inside the chest, the air moves out. So that will be away from this instrument. It is very similar to our echo probe. When the blood flows
Yes, sir.
towards the probe, it is red, positive. And when it moves away from the probe, it is blue, it is negative.
Blue. Negative.
Okay. So that's why when this negative pressure is being created, the flow was inside the chest. So there is a positive flow. And when positive pressure is being created in the chest, the flow is negative, that is flowing outside the chest.
Hmm.
Everybody is clear about this?
Yes, sir.
Okay. Now see what is happening in this ventilation when the ventilator is giving the breath. So if you understand that, explain this. Somebody should explain this. Anyone?
Yes, sir. This is a pressure time scalar.
Okay.
Top of the blue line, starting of the blue line, this is just starting from PEP, positive and expiratory pressure, and generating a peak inspiratory pressure, cycled by time, and
Great. So you have created,
And-
yeah, great. So Sanjay has explained in terms of ventilation technical terms. Now in simple terms, if I want to explain you, as I told you, when I am giving positive pressure ventilation, here you saw in normal natural, there was a negative pressure. So because it is a normal respiration is a negative pressure ventilation. But our ventilation, when we do the normal ventilation, it is positive pressure ventilation. Okay. So that's why you will not see anything which is negative. It is all positive pressure. The only thing is in inspiration, as I told you, there is always there is some residual, some pressure will always be there inside the chest that is there to keep the alveoli open. So when I want to create some pressure which will start the movement of air from the machine towards the patient, you need to create a higher pressure. So this is what is PIP. I am creating peak inspiratory pressure, that is a higher pressure on the ventilator, that will be a higher pressure from the minimum basic pressure, residual pressure, and hence the airflow, as you can see, will start. Do you see? So this is our inspiration. And then it will come down to our normal basic residual pressure. Okay. And then that pressure will be lower than what is being there in the intrathoracic. The airflow will start moving out, and then you will see a flow in the negative direction. So normal airflow, you will see, is same what is there in our natural negative pressure ventilation. It is very similar. But the only thing is, here we created a negative pressure inside the chest to cause this positive airflow. But in positive pressure ventilation, we have created a positive pressure outside in the machine to cause this airflow inside the chest. So this is from residual pressure, basic pressure. I have to have this much higher pressure outside to cause the airflow. This is PIP. Then it comes down and comes to the residual pressure, and that is PEEP. This is PIP and this is PEEP. And hence the expiration takes in this phase and the inspiration takes in this phase. Clear?
Yes, sir.
Okay, good. Let me see, there are few chats. iPhone 13 किसने है भाई? Okay. So till now everything is clear? Great.
Yes, sir.
Good. So now this slide is very important to understand what I told you, time cycled pressure limited. Okay. On y-axis we have pressure. On x-axis we have time. Okay. Understand. X-axis we have time. Y-axis we have pressure. What is this from here till here? What is this?
Inspiratory time.
Inspiratory, inspiration. Good. From here till here, what is this?
Expiratory time.
Expiration. Very good. Okay. So this thing you remember. This is inspiration. This is expiration. X-axis is time. Y-axis is pressure. Okay. This much. This is your ventilator breath. Okay. Now, what are the main parameters by which we can attain the ventilation? One is pressure. As I told you, by increasing and decreasing the pressure, I can control the flow. then the flow of the air itself, and then you have seen the time, and all these things, either they change volume or the volume changes these things. So these are the 4 things, 1, 2, 3, and 4, that will control the parameters of my ventilation. Clear? What are those? Pressure, flow, time, and volume. Everybody is clear about this? So these are the 4 things that control my various ventilation parameters. Okay. So till now I have discussed this. We will come to this everything later. These are, but to know these terms and everything is very important. So now I should know what are the indications. What are the indications of ventilation in the newborn? As I've written, you can see one is RDS, meconium aspiration syndrome, pneumonia, apnea, and shock. These are the few indications for ventilating the newborns. And when we say it is hypoxia, if the baby is on CPAP of 7 centimeters, and PO2 is less than 50 and not maintaining saturations, so that means for non-invasive ventilation, the baby is not maintaining. So there is hypoxia. That is again an indication of ventilation. And if we have respiratory acidosis, means your CO2s are high. Means you are not washing out the CO2. That again is the indication of ventilation.
Ventilation.
And then you have an increased work of breathing, even though your CO2s and carbon dioxide and oxygenation is good, but the patient is having a very difficult respiration. Okay, so then the patient will fatigue out. So again is an indication for ventilation. Okay, and what is a prerequisite of the baby to put on the CPAP? One of the prerequisite of the baby to put on the CPAP?
Spontaneous respiration must be
Yes.
there.
Good. So the baby should have a self-spontaneous respiration, should not have apneas. If the baby is having significant apneas on the CPAP, then that baby should go on the ventilation. That is very important. And then you have the CNS causes. So those are the indications. Okay. This is what I've just explained those. Okay. So when we talk about these modes, I will talk about those, all those things, inspiration, when is expiration, everything. These are exactly not the newer modes. Basically, these are just the improvement over the conventional ventilation. This is what we need to remember. And the examples are, this is what you must be hearing. SIMV, SIPPV, PSV, volume limited or volume targeted or guaranteed, PAV, all these modes. We'll talk about that. But once you will understand the basics of the ventilation, immediately you will come to know what I'm talking about. Okay. Okay. This is what we have already discussed. Okay. Now, so one is, if I talk in simple terms, mandatory ventilation, that is IMV. What is the full form of IMV? Anybody can tell?
Intermittent mandatory ventilation.
Intermittent mandatory ventilation. And then we have patient triggered ventilation. What is patient triggered ventilation? Anyone? So that is something, see, this is something as, you know, PM, sugar baby syndrome, and then you have a malnourished baby. I forgot the exact terminologies of PM because I have not seen a baby since years of PM. But if you have gone through the literature, there is one sugar babies, and then you have marasmic babies. So what is sugar babies? You are given enough number of calories, only deficiency is protein. Okay, they are over calorie babies. So in this, what you're doing, whether the baby wants or not, machine will keep on giving the ventilation. Okay, the machine does not bother whether this patient wants ventilation or not. Okay, it will keep at that regular interval, it will keep on giving the breaths. But here, machine is having some sensor that senses that now the patient wants the breath. So now let me give the breath. So that's why these modes are patient triggered mode. They are more in synchronization with the patient demand. So they are known as synchronized modes. Patient triggered ventilation is a synchronized ventilation. Okay, and this is unsynchronized ventilation. That's why it is IMV and this is SIMV. So what is the full form of SIMV?
Synchronized
Synchronized
intermittent
intermittent.
Great. So this is what is happening. IMV has switched over to SIMV, but just by putting on this. This thing has come in between. So just putting on this something which detects the patient trigger makes the IMV to SIMV. Got it? How it happens, we will
Yes, sir.
discuss. But the basic idea is clear. Basic idea is
Yes,
clear.
sir.
Great.
Yes, sir.
Okay. So I am going to before I will complete IMV today. So IMV is what? Ventilator will deliver the minimum breaths per minute, whatever is ordered to the ventilator. Okay. And it is irrespective of the patient, what the patient breathe independently. And the patient will keep on breathing independently by the base flow, the bias flow. We discussed that because even in expiration, there will be some flow in the circuit and within the respiratory, the whole respiratory tract, because that is minimum flow or pressure of the air which is needed to keep the alveoli open. Okay. So now in positive pressure ventilation, artificial ventilation, there are two systems that are working. Two systems are working. One, patient himself. Okay, because the patient is taking its own spontaneous breaths. That has got its own respiratory rate and own I time. Two things. Okay, spontaneous breath the patient is having, that has got its own rate and own I time. And then you have the other one, other system that is working, that is ventilator. It has got its own set rate and set pressure. And then we have I time also in that. We set I time in the ventilator, everyone.
Yes,
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 sir.
sir.
Yes, sir. Yes, sir.
So that's why there is asynchrony, there is asynchrony, because these two systems are running parallel to each other. They are not talking to each other. Ventilator is working as per the orders given to the ventilator, and patient is working on its own terms. A lot of fighting is going on in between these two. Okay, so now ventilator delivers the minimum breath per minute what is being ordered to the patient. Patient is still able to breathe independently from the base flow in the circuit. Chances of asynchrony are high. So both the systems are working. Patient himself at its own this thing, and this is what is happening. So it's all asynchrony which is happening, and that is what is IMV. So what the ventilator is doing, it is delivering the mandatory breaths at fixed time interval, at whatever time we have given, irrespective of the infants or babies' spontaneous breathing efforts. And this is what it is. So I will have the triangle for spontaneous breaths are like this, for ventilator breaths are like this. So these are all spontaneous breaths. So what is this in the starting is here. From here the breath has started. Okay. And these are your ventilatory breaths. So these are your spontaneous breaths and these are your ventilatory breaths. Okay. See, here your spontaneous breaths are starting. And here your ventilatory breaths are starting. This blue line. Red is spontaneous, blue is ventilator. So what is this in between these two? So this is the inspiration has started of the ventilator breath, and here the inspiration has started of the spontaneous breaths. So this is the starting of the inspiration of spontaneous breath, and here is the starting of the inspiration of ventilatory breaths. So what is this difference is? This is your inspiratory asynchrony. There is asynchrony, isn't it? Between the ventilatory breath and the spontaneous breath. So this is your inspiratory asynchrony. Okay. So what is this? This is the end of your expiration of the ventilatory breath, and this is the expiration of the spontaneous breath. Here. Here your expression has started for the spontaneous breath. Here the expression has started for your ventilatory breath. So what is this?
Expiratory asynchrony.
Great. So this is your expiratory asynchrony. So this is your inspiratory asynchrony. This is your expiratory asynchrony. So in IMV mode, there are both inspiratory asynchrony and expiratory asynchrony. Okay. So asynchrony is the norm in the IMV mode, in inspiration and expiration both. So what happens with the asynchrony? Work of breathing increases, high chances of pneumothorax. In preterm, IVH increases, barotrauma increases, the tidal volume sometimes goes very high, and there is a hindrance in the gas exchange. You may have hypercarbia and hypoxia. Even there is a difference in a lot of variations in the blood pressure, and the patient will keep on fighting. So these used to be in the olden time when we do not have that sensor. Okay, so patient used to fight a lot. Okay, and then what we used to do, we used to start sedations and muscle relaxations in those patients. Now nowadays, if you are posted in NICU, PICU, in PICU, I don't know, it may be there, but in NICU, did you notice any deep sedation for any babies or muscle relaxant used in the babies? Anyone who has been posted in
No.
NICU?
No, sir.
No, because of the better modes of ventilation, that asynchrony is being, it has not been decreased to 100%, but quite a few amount of asynchrony has been reduced by the better modes of ventilation. Now you see this, these are the older ventilators we used to have. Now we don't use it. So what we do is, this is 750. So this is your flow curves. Okay, so tidal volume, flow, and this thing. So what is being there? What we have done is we have removed a sensor from the patient ET and the circuit of the ventilator. Okay, and did you notice what is happening to the baby? See, all these flows and this thing is gone. So it is just a basal flow. How much the ventilator is giving? Because whatever is happening, actually, we have removed the sensor. So after removing the sensor, we have made SIMV mode to IMV mode. And see how anxious this baby is looking. Dekha apne? How bad the baby is fighting and how bad the baby's expressions are. So this is what is known as the asynchrony. This is what happens to the patient. Did you notice the baby's anxious look? Everyone?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So in previous olden days, when these sensors and synchronous mechanisms were not available, what people they used to do is they used to increase the rate of the ventilator. So after some time, when the patient used to fight, the ventilator rates were higher than the patient rate, the patient used to give up. So then the ventilator used to overtake the respiration of the patient. So what it causes, if you increase the rate, what it will do indirectly? These two
CO2 washout.
Okay, CO2 washout will be bad. For why it is bad? CO2 washout is why it is bad. Why CO2 washout is bad? Let me have a poll on this.
Lung,
Let me have a poll on this.
Cerebral vasoconstriction.
Okay. Let me have a poll on this. This will be last poll. Huh? Why CO2 washout is bad? Okay. Let's have why CO2 washout is bad. Causes lung injury, causes brain injury. Good. Everybody is intelligent, huh? So it causes brain injury. What it does?
Cerebral vasoconstriction. Cerebral vasoconstriction.
Good. Very good. So it causes the vasoconstriction and causes the white matter injury. Therefore, so but this rate, increased rate, will also cause a lung injury. And what is this inadvertent PEEP? What is this? Anybody? Also known as auto PEEP. Have you heard of auto PEEP? Auto PEEP सुना है किसी ने? What is auto PEEP? Okay, fine. We will discuss that. So it causes inadvertent PEEP or auto PEEP, increases the PIP, hence causes lung air leaks and lung injury. Therefore, it needs sedation and paralysis, which has got unacceptable side effects. Okay, so there are side effects for that. So what are the best ways to synchronize is synchronize the ventilation with the patient breath. So patient demand, the ventilator should recognize and hence should give. This is what I explained in your 2 or 3 slides, previous slides, that then the breath when the patient wants, only then the ventilator should give the breath. Otherwise, ventilator should not force in the breath. So ventilator delivers a positive pressure breath just at a time when the patient has begun to inhale. So it should recognize that. So there are various ways of recognizing. So one is by putting in the sensing device. When the spontaneous breath initiates in the patient, there should be a sensing device with sense this. It gives an input to the machine that now you should initiate the positive breath, and the ventilator gives the positive breath. So this is what we can achieve with this sensing device. Okay, see, this is your ET. This is the piston, your machine, which is causing the pressure, increasing the pressure, generating the pressure in the machine, and hence that airflow will be forced into the ET towards the patient. Okay, so this is your controlled IEM. This is your mandatory ventilation. Okay, intermittent mandatory ventilation goes in, out. There are no sensing device. So now if I put a sensor here, as soon as the patient starts the breath, the machine will sense through this, and hence it will give a feedback to the machine. Now you create the PIP, and hence the machine will create a PIP. So this is your synchronized breath. This is your unsynchronized breath. The difference is this place. Here, this small negative notch. That why it is negative? Because that is a natural breath which the patient wants to take, and hence it has been detected as negative. So this has been sensed by here that there is some negative pressure which has been generated in the circuit. So that is it, machine sense that it is because of patient wants to initiate the inspiration, and hence it gives the feedback to the machine. The machine generates the pressure and pushes and forces the air inside the baby. So that's what is known as SIMV, synchronized intermittent ventilation. Clear? Everyone?
Yes,
Yes, sir.
That's why we also call it PTV, patient triggered ventilation. Synchronized mode, delivery of mechanical breath in response to trigger from the baby. And that mainly commonly comprises of 3 modes. SIMV, there is synchronized intermittent mandatory ventilation, assist control or SIPPV. I will talk about what is the difference between AC or SIPPV and SIMV mode, and the pressure support mode. So these are the 3 commonly used patient triggered modes what we use in our ventilation. I hope those who have been posted in NICU, PSU are well versed with these 3 terminologies. Are you aware of these 3 terminologies, 3-4 terminologies?
Yes, sir.
Yes, sir.
Yes, sir.
So it is only a few ventilators have got different terminologies. PTV in SLE refers to assist control, and SIPPV in other machines is same as assist control. So it is only because of their trademark they have to use different terminologies. So that's why it is different names. But these are the 3 basic things modes we use as a synchronized mode or patient triggered modes in the ventilation. Okay, clear? So I will stop it here, and the next class we will do it on Monday maybe. Okay, on Monday we will take a class and we will continue from here. Clear? And I will put the recording on the Nirmal Academics and share the link for that also in the group. And anybody wants to ask anything till now what we have discussed, I am happy to answer.